Hi, this is another instructive case that I would like to share with you. My name is Wolfram Klapper from the Department of Pathology, Hematopathology section in Kiel, Germany. And I want to address a very common topic with this case. The topic is a little bit about what should I do if I don't see anything relevant in my H&E slide. So this is the first case. This is the case I want to present today. It is a 44-year-old female that had a diffuse large B-cell lymphoma 1.5 years earlier. Now a PET CT showed a positive lymph node, and this lymph node was excised. It was a left axillary lymph node. And I want to show you this case, the case that we have received. So this is the biopsy of this patient. You see it's a lymph node with generally preserved architecture. Actually, when we were measuring it, it was not 1.5 centimeter. It was, in my opinion, it's just a maximum a centimeter large. And if you go into detail on this and move over this area, the first thing I'm always checking is, do I see germinal centers? And do these germinal centers also appear to be closely correlated to the outer areas of the outer parts of the lymph node? We see here the germinal centers. I will look into that in detail. We see paler areas that we have to check. Maybe it's a T-cell nodule, or this is monocytoid B cells or plasmacytoid monocytes. And we're just moving over that, having in mind that we are looking for a diffuse large B-cell lymphoma, moving over that, seeing that nodularity, this picture of where that's colorful, that's diverse, it's very unlikely that you see that you find this lymphoma in here. Here in the higher magnification, you see the well-preserved germinal centers. At least the preservation is, I would say, it's preserved in that sense that you see the macrophages, the stereosky macrophages. However, the outer borders are a little bit poorer preserved, and that looks a little bit like regression of the lymph node. So we move over that, and we don't see any relevant features. Here's an area that was appearing a little bit paler. It's hard to see. So what this exactly is, if you look very close, I'm going to go to a high magnification. You see these are medium-sized cells, like look a little bit centrocytoid-like. You see some, at least here up here, you see a little bit of granulocytes in there. So that might in fact be, here's another granulocyte. That's a peculiar mixture you see usually in monocytoid B cells. So what am I going to do in these cases? So that looks like an unsuspicious lymph node to me. What I'm doing in these cases is I'm going to stain them for CD20. And this is what I'm doing here now. You see that the preservation of the architecture is still detectable. So you see the cortical arrangement of the lymph follicles. You see also a little bit that that the B cell areas are a little bit expanded. You see some activation of B cells also in the interfollicular region. Here you see that you see where on the right we are here. Sorry for that. And this is the germinal center. And you see that in the interfollicular region there are also larger activated B cells. So that's something we find in a lot of inflammatory conditions. The other thing I'm going to do is always to stain for Ki67. That helps me to identify these germinal centers. And you see here that some of these germinal centers in Ki67, as expected, they are highly proliferated. And the outer borders are relatively well defined, whereas others actually fit to what we have seen morphologically here, have a little bit reduced proliferation and a little bit less well-defined outer borders. So that's something we might see in regression of lymph nodes if a hyperplasia is regressing. If you feel uncomfortable with that, usually you can also go for a BCL2 staining to be more sure that this is in fact reactive. So actually my diagnosis in this case is a reactive lymph node. That would be what my diagnosis would be. And I just want to go over a few slides with you to show you how I'm going to approach it and why I'm going to approach lymph nodes like that. So the first question is, if you see a lymph node where you don't see any morphological changes, that just shows hyperplastic normal tissue, is should we do any immunohistochemistry or not? I think if the clinical context is a solid tumor, where this is a staging biopsy, it's not necessary if the conventional histological picture looks normal. However, if the clinical context is a lymphadenopathy of unknown reason, I would always go for some stainings, a very few that I'm going to show you how I select them. So if I don't see anything in that cases, what should I actually stain? First of all, I need to know why I'm going to do staining. First, if the context is lymphadenopathy. And my goal would be to identify with my immunohistochemistry subtle architectural changes. And as a second goal is also to check for lymphomas, which we know infiltrate the lymph node partially. So that was actually the question: what kind of lymph nodes infiltrate? What kind of lymphomas do infiltrate the lymph node partially? These aren't many. As you can see here, there's an indolent lymphoma like follicular lymphoma and marginal zone lymphoma. But aggressive B-cell lymphomas, like in our case, diffuse large B-cell lymphoma, Burkitt's lymphoma, virtually never partially infiltrate the lymph node. So it's very unlikely that we miss an aggressive B-cell lymphoma by conventional morphology. We have to take care of T-cell lymphomas, which can partially infiltrate, mycosis fungoides, angioimmunoblastic T-cell lymphoma, and anaplastic large cell lymphoma. And of course, Hodgkin lymphoma is a typical example of something that can partially infiltrate. So what I do now is a little bit, when I adjust my stainings according to the situation. Is it a children or a young adult? I'm expecting other lymphomas than in elderly adults. And that's why my staining panel differs a little bit. You see on the left, that's what I would do in young adults. Yeah, and this case is a little bit on the border between young adults and real adults, let's put it this way. So I would stain for CD20 and CD30 and Ki67. Why should I do that? First of all, I'm going to use CD20 and Ki67 as we did in this case to identify architectural changes. And I'm going to do the other stainings or combination of these stainings to identify the lymphomas which can partially infiltrate and that I might miss. And in children and young adults, it's mainly anaplastic large cell lymphoma and Hodgkin lymphoma. So we need the CD20 and CD30 staining for that. And for the very rare cases where you see infiltration by lymphoblastic lymphoma partially, Ki67 is very helpful to identify an area of high proliferation. In adults, it's mainly follicular lymphoma and Hodgkin lymphoma that I'm trying to identify. With the same stainings, I would also be able to, for example, to identify nicely partial infiltration by a marginal zone lymphoma. So that would be my staining in a case where I don't see really anything. You see that we try to limit our stainings and also to select them rationally. And more importantly, we try to stain here and kill always the same markers. So we get very familiar with these markers, how they look under different conditions in reactive tissue. Thanks for watching and bye-bye.